Good morning, students and teachers. This CIO was founded on 11th November of 1962. This year we'll be having a golden jubilee of CIO. This year was established with the aim of imparting postgraduate training in the orthopedics. This was the first place in Safdarjung Hospital where the PG course started. So, and that the stalwart at that time was Dr. Durai Swami. The aim was to train postgraduate students. Gradually, as the time goes on, that PG teaching was at very low ebb. And today I am seeing the example that most of our registrars and PGs are not here. So they are not sincere about it, and this is very bad. To pass an MBBS, MS examination is not very difficult if you are regular in your classes, if you are regular in your rounds, and if you teach, if you learn or read for 2 hours in a day, I think it is not very difficult to pass an MS examination. We have hardly 5 or 6 long cases in orthopedics and plenty of short cases. In the last examination, what I observed, I was when Dr. Swami was examiner, that most of the candidates were not able to even give a proper history. And examination part was also not very good. If you are very good in examination and the history taking, I think you're 90% that you will pass. Very few examiner goes up to taking the treatment part. If you've gone through the treatment part, that means you will pass. But majority of the people fumbles in the history taking and clinical examinations. So the purpose of initiating this course is to train all the postgraduates and prepare them how to prepare themselves for examination. This is exercise in which there are long cases, short cases, X-rays, instrumentation. So you should feel free. There should be no hesitation in asking questions from the teachers. Because if you hesitate here, you will have a problem in the examinations. So in that view, you should learn and should interact with your teachers. And don't feel hesitated. And one thing which I have observed in examination is the language. Some of the students come from the background in which English is not fluent. So don't hesitate to speak in Hindi also. Nobody will mind it, but if you are able to express in Hindi or in your own language, it doesn't matter, unless if you are able to express it. If you are not knowing English well and you are not able to express, then you will fail. So no examiner will mind in which language you are speaking. So make sure that if you are not very good in English, doesn't mean that you should not express yourself in Hindi. So this thing because I have seen this is happening in many examinations. Because I have been to different parts of the country for examination, and where the English is not a good medium. And even if the student knows the subject, he is not able to express. And in examination, you have to express yourself. And examination is a tricky part. If your first phase start is right, you will keep on going. And if you fumble in the very beginning, you are off the track, and it is very difficult for you to come on the track. And I appreciate the efforts of our faculty to organizing this course, and especially Dr. Professor Ramesh Kumar, who has taken great interest and lead in this direction to have a postgraduate training, because we are asking postgraduate to attend the classes, and the response was very poor. Ultimately, we do not want to give any this punitive action, but we are forced to do it. We started marking absent for them who is not coming to the classes. These classes are not meant for us. These classes are meant for you people. If you don't take advantage, what kind of doctor you will become? So at least when you are in PG, you are doing only 9 to 4 duties, and hardly there is one emergency day per week. So there is plenty of time to read. You start with the small books, TEAS and just apply. Then you can go on to the other higher books. But don't start with the Campbell and bigger books, and in the end you are not knowing anything. You should know everything of everything. So first I suggest you that go through the apply, but go through apply in depth. You should know A to Z from the apply. Then if you want to go through higher, know something higher about the subject, you can consult other books. This apply and the Campbell and other books are the reference books. And another thing that I have felt, that students coming to the OT, they don't come prepared. What? Because OT list is made 1 year in advance, 1 day in advance, but when the person reaches in the OT, the person who is assisting in the case, he doesn't know anything about the case. He doesn't know about the history of the patient. He doesn't know which side is to be operated. He doesn't know how to operate, what incisions to be given. So you should come prepared. If you keep on preparing yourself every day, I think in the end you will have no problem in appearing examination. So this course is basically for the purpose to orient you towards the examination. Because in the whole life, there is plenty of time to research, plenty of time to practice, but unless you do a methodical way, it will not happen. So there is a team, we have got a good program of 2.5 days. So orient yourself, and this time we have not invited the faculty from the outside, but in the future, if we see the success of this program, we will invite the faculty from outside also to give a specific talks on particular topics. So it is for your benefit. Let it be an interactive session. Don't feel ashamed. If you don't know, doesn't matter. You can read it. So examination is also a technique or trick to pass. So in this course, you will know how to appear in examination. It is not a some theoretical examination, this thing, but you have to pass through a practical. If you are passing in the practical examination, I don't think anybody will fail in theory examination. So your long case and minimum 2 short case is a requirement that you should good in those things, and nobody can fail you in examination. But you have to make effort for it. We are here with you to guide you, to teach you, but you have to show your sincerity. And with these words, I thank all of you. Thank you.
I would request Dr. Ramesh Kumar, Professor CIO, to facilitate Dr. B.K. Sharma with a beautiful bouquet. Thank you. I would request Dr. Ramesh Kumar to come here
late, 40 minutes. So it is a pleasure to see you here. Although we expect that a lot of the PGs should have come here, I think they are slightly late. So as our director has told you, the purpose of this symposium, so it is very clear, and we hope that after this symposium, at least you will know how to start clinical examinations, history, and how to come to a particular clinical diagnosis, and then how to proceed for the discussion part in the examinations. After that, we have also the X-rays, instruments, bone specimens, all things are there which are required to know for the PG exam. So I think if you are really sincere, then you will be able to know a lot of things for your benefit. So with this short note, I would like to start this program without delay. So further, let us have first hit session today. Thank you.
Thank you, Dr. Ramesh. We will be starting with a case, a clinical approach to a case of hip by Dr. M.K. Swami. And before starting, I would like to say something. The more you sweat in the field, the less you bleed in the war. You got it? Yes. Got it?
Respected Director, Dr. M.K. Sharma, faculty members, and students. So I am the opening batsman, I don't know how I'm going to perform, because there was some problem in the slides yesterday night. I was going through, there were a lot of mistakes, I tried to correct it. Okay, I'll start with the examination of the hip. The hip. You must go back to our anatomy classes or anatomy, what you have learned in anatomy. You know, sometimes it is asked, don't think that this question is not asked in the exam. It is a synovial joint. It's a multi-axial ball and socket type of synovial joint. It has got a sternum and head of femur. Head of femur outflows with a sternum. A sternum is about half the span, and femoral head is about 2/3 of the span. That's why there is large range of movement that is present there. And it is protected by very strong ligaments and capsule. You can see the tubofemoral ligaments. Most important is this one, iliofemoral ligament, or ligamentum below, and posterior ligament, and also the capsule around it. So these are very strong ligaments are present around the hip, which are responsible for stability, along with the acetabulum, labrum of the acetabulum, with all these things. And that's why it is very, very stable. See, let us see the forces that are acting on the hip. While standing, it is about, because our body weight, why it is important is, there are a lot of things that are going. Obesity. Nowadays, every country is going toward this stage. Because of the problems are more. Wear and tear of the joint should be more. If there is some pathology in the joint, it may go increasing to a greater extent. On standing, about 3.3% of the body weight is borne by the hip joint, each hip joint. Standing on one leg, it is about 2.5 times of the body weight. Walking, it is about up to 5.3 times of the body weight. It is borne by the hip joint. Walking upstairs, it is 3 times of the body weight. And running, it is more than 4.5% of the body weight. So there is a lot of loads are acting on the hip joint also that are responsible for the wear and tear of the joint. Coming to the examination of the hip joint, what we have to see. In the history, most important in the history. So you have to take the history. How you are going to take the history? First you take ask his name. Age of the patient is very important. And next, from where he is coming, which place is coming. Some diseases are common in some places, like fluorosis, if you think of it. There are some reasons from where the people are hailing. This is quite common. And in Karnataka there is one place where Handigodu syndrome. Have you heard of it? No. That was, I think, about 25-30 years back. The villagers, most of the villagers around that area, they suffered from this disease, where there was stiffness of the joints, they were not able to walk. This is due to the chemicals they were using in the fields, and they were eating the fish and crabs of the area, which were loaded with this chemical. That was called as Handigodu is a village. So this thing, that's why we have to ask the place from where it is coming. If you think, and whatever the history, you have to present in a chronological order later on. Age of the patient, if you think it is infancy, if the patient is a child, you have to think of congenital abnormalities like DDH. And if it is little bit higher range, if it is not a congenital, later on the patient develops any symptoms, you have to think of Pate disease and other things. Middle age, osteoarthritis, and other diseases like tuberculosis and septic arthritis, they can occur at any age. Another common case what we get in examination is Tom Smith post-septic sequelae. That's a commonly kept in the examination. You must know about it. And whatever the presentation when you do later on, history, how to take histories, you must present it in a chronological order. Like, okay, a patient comes, first he says he had some trauma. You have to say trauma for 6 months. Then not able to walk for the last 6 months. Later on, for the last 3 months, he has got difficulty to walk and limping. These things you have to say in chronological order. Not like this, patient is limping for the last 3 months, history of trauma for the last 6 months, like that. And the mechanism of injury is also important. How he has fallen, suppose if the history of trauma is there, whether it is a severe injury or it is a trivial injury. So, because that has got a bearing on the type of trauma what he has received on the hip. Because in elderly people, just stumbling, they can have fractures. And coming to the pain, if the patient complains of pain, what are all the things you have to consider in the pain? You have to present what is the pain and where is the location of the pain, whether it is in the hip, and what is the type of pain, whether it is a throbbing, dull, boring pain, or severe acute pain, stabbing pain. You have to be able to say what is the type of pain, because it has a bearing again. If it is a throbbing pain, that means it is an abscess. If it is a dull, boring pain, that means it is a chronic disease, inflammatory disease like tuberculosis. And radiation of the pain, from where to where it radiates. Usually the hip joint, the pain radiates to the knee joint because of the same nerve supply. And snapping, there are some cases where there may be history of snapping. That is in case of especially gluteus maximus contracture or iliotibial contracture. Progression of the symptoms, how the symptoms have progressed. This pain has progressed. First, to start with, it was very mild, later on increase in severity. That means the disease is progressing. Exacerbation factors. So on walking, the pain increases. And elevating factors or on taking rest, it decreases. Or the patient is having night crash, night pains. All these factors regarding the pain you have to give in the history. And next comes, other thing is if he has got limping or difficulty to walk, then you have to talk about difficulty in weight bearing. What is the difficulty? First thing. Whether he is able to walk from the beginning or walking for a short distance, then he gets pain and he has got difficulty. Or walking for longer distance, some more distance, he is not able to walk at all because of the pain and he has to take rest. These are the things how you have to present. And are there any deformities? whether the patient complains. These are the complaints, but sometimes the patient complains of deformity. He has got equinus deformity or flexion deformity of the hip. He may complain of these things. And limping. Limping again the same thing, you have to ask whether limping is present from the first step onwards or later on it appears on walking for short distance. Is there any stiffness? This is common in case of rheumatoid arthritis, morning stiffness, and also in osteoarthritis. So morning the patient will have stiffness, later on as the patient walks, it gets relieved because of activity of the muscle as well as along with lubrication. Is there any disparity in limb lengthening? That you have to ask. And the patient may tell there is this limb is short or long, whatever it is. And of course, later on, once all these things are pain, this is completed, then you ask, suppose the patient may give this fever or not, but you have to ask probing questions, whether he had fever. Fever, to start with, he had fever, then he had pain, or he had pain and later on fever appeared. How long he had fever? Is it a continuous fever, or it is a waxing and waning type of fever, or evening rise of temperature? All these things is necessary in the history of ask about it. Then the other thing you have to ask in the history is about weight loss. Is there any loss of weight? Because some diseases like tuberculosis, the patient may complain of loss of weight. And you have to other things is, this is compared, coming to only to the hip, whatever the, symptoms of the hip, whatever the history depending upon the problems in the hip. Then you have to ask other things also about systemic complaints. Systemic disease, what is having in the hip. The problem is more in the hip, not in other joints. But he may be having problem in other joints also, like rheumatoid arthritis, ankylosing spondylitis, or tuberculosis. So he may be having chest problems in tuberculosis, or he may be having other joint involvement, like in rheumatoid arthritis, exacerbations, remissions you have to ask in these cases, and ankylosing spondylitis, where it started. It started usually in the gluteal region, usually SL joints, that is more first. Later on it spreads upwards. Or he has got any problem in the spine, back here, pain in the cervical region. All these things should be asked in all these cases. And then, depending upon it, the occupational function demands of the patient. What is his nature of work? Is he a farmer, or is he a desk operator, or sitting in the office, or he has to work for long distances, or is a manual laborer, and how his occupation is affected by this disease. And you have to ask his activities of daily living, whether he is able to squat, sit cross-legged, is there any difficulty in these activities? And depending upon this, you may ask some of the probing questions. It may be, depends, by this history you know what it is, what type of disease. It is an infective or a degenerative, or it is a tumor, or something will come to know exactly what it is. Is there any swelling which is increasing, that denotes there is some tumor in the upper part of, or in the hip. In these cases, you may ask some of the symptoms or the history of any other primary disease anywhere in the body. That's an important thing you have to present. You have to say about those things. Bleeding per rectum, sputum in the, hemoptysis, any other problems they have got. That you have to inquire about those things. This is about the history of present illness. Coming to other things you have to ask about is personal history. Personal history is very important, especially in the hip, because nowadays what we get, a lot of cases we get is AVN with osteoarthritis, secondary osteoarthritis. In these cases you may ask about is habits like alcoholism, chronic alcoholism. Second thing is tobacco, smoking. These things you have to ask about the personal history. And the family history, some of the diseases are they run in the families, like rheumatoid arthritis, ankylosing spondylitis. So that's why it is important to ask about the families, or tuberculosis, exposure to tuberculosis, whether anybody is suffering from tuberculosis in the family. Once you have completed the examination, history taking, and you have presented it, then it comes to the examination. In the examination, of course, you have to say about general physical examination of the patient. Whether it's anemic, cachexic, clubbing, all other things you know very well. Lymphadenopathy, all these things, general physical examination. You have to examine cardiovascular system, respiratory system, abdominal system, whether there is any significant thing is present in that sort of thing. Then coming to the local examination. The first thing in hip examination is gait of the patient. You have to ask the patient to walk. Some boys they present late after the inspection, palpation, and then they come to the gait. Better you start with the gait. You ask the patient to walk and observe the gait. So there are various types of gait, and in different diseases you will get different types of gait. By gait itself you will come to some conclusion what type of disease he is having. One is Penrose gait, know it very well, where there is dipping of the pelvis when he bears weight on the affected limb. Opposite side dips because of the mechanism, that is, liver mechanism is disturbed in this case. Most common cases are in case of fracture neck femur or DDH or waddling gait, bilateral DDH. It is very rare, but we can get some of these cases where you get a waddling gait, or it's called as a duck gait. And the most common gait, what you get is antalgic gait. Because of the pain, the patient will have antalgic gait. And we must be able to explain what is antalgic gait. Patient is not able to bear the weight on the affected limb, and he swings to the opposite side quickly. It doesn't take weight, and the step what it takes, the distance between the steps is less. And he may not be having heel to toe gait, foot flat, he just walks like that. Or an ataxic gait that is common in neurological conditions, not in orthopedic in hip. Short limb gait is another thing which is quite common in case of cases where hip joint involvement is there, where the patient takes short steps and also he swings to the same side because of the short limb. There are other types of gaits, that is like, hand to knee gait, what you get in case of gluteal maximus paralysis, in case of polio is there, then you get that type of gait. Or a scissoring gait, what you get in case of diplegia. Or you may get what is called a circumflexion gait in case of hemiplegia. You must know the types of gait and what is the alterations that occur in the gait. Coming to the examination of the hip proper. The most important thing is you have to examine the patient in the standing position. First, in the standing position, you have to look from the front, from the side, as well as from the back. And you have to extend it. It's only inspection, not palpation. And palpatory on all things, you can do it in recommended position. First thing is attitude of the limb. In standing position, what is attitude of the limb? Is there any flexion at the hip? Is there any flexion at the knee? Or equinus at the foot? How is standing? And is there any rotation of the rotational deformity of the limb? You must know. And then the most important thing is you have to look for anticipital spine, whether they are at the same level or at different levels. So different deformities, they may be at different levels. It may be riding higher or it may be at a lower level. You must be able to say that. And level of patella, whether it is at a higher level or a lower level, level of medial malleus, as well as is there any shortening in that limb, wasting of muscles, that's always you can see from the front as well as from the back as well as from the side. From the side, when you have, and also you have to look for any scars, NSS, all these things. Is there any swelling in the upper part of the thigh or in the hip region anteriorly? You must be able to tell about those things. And then in the standing position, from the side, you must look for the trochanter, prominence of the trochanter. Is it prominent? Usually in all these cases, what happens in a long-standing case of hip disease, there is wasting of muscles, and the trochanter looks prominent most of the cases. And you have to look for the spine to exaggerated lumbar lordosis, which you can see in a standing position. That means he may be having some other deformity in the hip. That's why there is compensation of hip flexion deformity by deformity of the spine, like exaggerated lumbar lordosis in case of fixed flexion hip deformity. From the back again you have to look for the gluteal fold. Is it at a higher level or lower level? Is there any wasting of the gluteal muscles? And posterior spine, where it is at a higher level or a lower level. If PSI is at a higher or lower level, definitely PSI is also will be at a higher or lower level. Sometimes the boys commit mistakes. They will say PSI at a higher level and PSI at a lower level. That cannot happen. Okay, don't commit gross mistakes like that. Because PSI is if it is at a higher level, definitely PSI will be also at a higher level.